So thank you again for inviting me to give another talk. And this one is going to be about primary brainstem hemorrhage and management of it. And we published our experience and our review on this 2 years ago with Sophie Wang and Yang, who helped me also with this publication and presentation today. So I'll make it a little bit quick because it's not really a surgical thing, but I think we learned in the last couple of years, there's a lot of debate and we learned some things that are important as messages. Now the majority of the brainstem hemorrhages are certainly in the pontine area. They are, as you can see here, incidence is 6 to 10% of all spontaneous intracerebral hemorrhages. The mortality rate is still very high, up to 50%. I will come back to this later on. And the etiology is mostly hypertension. Of course, there can be other reasons for brainstem hemorrhage, like vascular malformations or secondary hypertension. However, those other reasons, then they are called secondary brainstem hemorrhage, and I will get back to this thing too. Now you see a very old publication up there, which says that most of the patients have coma and definitely vomiting, headache. Some are in a mute state or in a semi-coma, so this has not changed much despite a lot of years that have passed by. Of course, loss of consciousness is a very clear sign for it, and depending on where the hemorrhage is, you might have a quadriplegia or oculoparesis, and of course also vomiting. So the early primary coma is a very significant sign for primary brainstem hemorrhage. Also the respiratory disturbance, most of the patients are intubated already outside when they come into the hospital and get their CT. Now pontine infarcts itself are slower in the clinical course, whereas bleedings have this disruptive element, and therefore also the clinic goes very quick. The outcome in brainstem hemorrhage is generally better in normotensive patients than hypertensive patients. This is something that is very important and discussed many times, but it is very important here to distinguish between primary and secondary hemorrhages, for example cavernomas, as the prognostic outcome is significantly different, and of course also the indication for any kind of surgery. And you can see here now, this is very important. So Rubinstein in 2004 looked at this primary against secondary very intensively, and you can see on this table on the right side that the patient in the primary group had they are definitely older. It's certainly possible also to be very old and have a secondary bleeding, but in the average they are older. In average, they have 2/3 have hypertension as a reason, whereas only 1/3 have it in the secondary group. And now very important is the mean initial Glasgow coma scale. And you see here, of course, there's a big variety, but the mean is 11. Now the secondary group with cavernoma, for example, they rarely get comatose. In this series, actually, they had none. So the lowest GCS was 12. That's it. And not 3 or in coma like the other one. So that's very, very important to know to distinguish already brainstem hemorrhage from each other. Interestingly also, as you see below, the intraventricular hemorrhage, IVH, so 33% of the patients had it in the primary group, and in secondary group it was only one patient that had it. And that might not even be a cavernoma, it could be something else like a venous bleeding or something, but it's very rare to have an intraventricular hemorrhage for these patients. I tell you this because now you will see a recently studied paper in stroke. So one of the really the best cerebrovascular papers, journals that you can imagine. And this group around Chen were using data from the INTERACT study. The INTERACT study was looking for how to manage the blood pressure, and depending on how quick you manage it, it could be a better for the patient or not. So they were looking at all intracerebral hemorrhages with more than 2,000 patients. And here they picked out the brainstem hemorrhages and the cerebellar hemorrhages. And if you look at these numbers carefully, they had 92 brainstem hemorrhages, which sounds like a big series and a lot of experience. But then downstairs at the GCS score, the lowest was 13. So out of basically 100 brainstem hemorrhage, they had none in coma. So this is definitely not a respectable series, and I cannot imagine how this manuscript got published, because this is definitely not the normal number of brainstem hemorrhage. This cannot be true. And how does this number come across? Now, the intention of this INTERACT study was that they wanted to have a lot of patients and look on the blood pressure. And a lot of Chinese centers participated in this study and provided patients. And I also see this as an editor. There are many manuscripts submitted nowadays where patients are treated for brainstem hemorrhage surgically, and the patients are doing very well preoperatively, and they have only a CT initially, and this does not confirm that is really a primary hemorrhage, because those numbers that just do not fit. So really read and interpret the literature carefully. In this case, despite a high impact factor, the series is just really bad. It just doesn't count. Now, Sophie Wang is now working in Germany, and she pointed to me this interesting, not serious yet, but she looked at the numbers of brainstem hemorrhages or hemorrhages in general in Germany, and as you can see, the red one, the numbers of general intracerebral hemorrhages is basically the same, around 35,000 per year. It didn't really grow and it didn't go down. Now the SAH, SAB, so the suprarenal hemorrhages, they're also the same, which is a little surprise because smoking really went down in those 10 years. However, the brainstem hemorrhages, they went down from 5,000 per year to just 2,000 per year, which is statistically significant. So there is a reason why brainstem hemorrhages are going down, and we still don't know it yet. What's the reason? However, also the mortality for brainstem reason was also lower than reported in the literature. So she's preparing this as a manuscript, and this is upfront data for you to share. Now, what do we do? How do we treat brainstem hemorrhage patients? It's mostly conservative management. The patient comes to the emergency room, certainly a neurological check, as you can see here. You have to do a CT scan, maybe with a CTA, to be sure that you have no arterial supply or any AVM or fistula. And then you have to decide whether you put an external ventricular drainage for hydrocephalus or for monitoring. The patient comes to the ICU. You should consider a re-CT in the first 24 hours just to see how things are going, maybe a second bleeding or not. Sometimes on the initial CT there could be a spot sign, which would be contrast enhancement output in the first CT while the CT is going, and that could lead to actually more bleeding in the second CT. Of course, it's very important to have a close clinical assessment with monitoring, airway protection, cardiovascular control, temperature management, coagulopathy management. Maybe the patient had medication for his coagulopathy, and of course electrophysiology. And of course there is the decision what to do. You see on the right side palliative care black, so maybe don't do any treatment anymore, palliative treatment. Or if the patient responds to something like electrophysiology or clinical improvement, then you would go regarding neurorehabilitation. Now the mortality rate of all brainstem hemorrhages, as we see from the old series, is about 50%. And even in the newer series, you see Huang here, with 171 cases, 68 died. Again, half the patients, even after 20, 30 years, about half the patients really die. So this is really a very bad hemorrhage and a very bad diagnosis for the patient, of course. What are the prognostic factors from pontine hemorrhage? And we see the admission of the Glasgow Coma Scale has a significant prognostic factor, significant prognostic factor. The coma, of course, how the patient was seen first time. The lesion size, however, the lesion size is also a reason, but the hemorrhage location, the lesion location, remains questionable whether that really has an impact. And we looked into this closer also with other publications, and you see here that the three big hemorrhages of basal tegmental, bilateral tegmental, or massive hemorrhage, the mortality rate goes really up, 70 to 90%, whereas the unilateral small tegmental one has only a mortality rate of 5.9. So we have a significant distinguishment of these hemorrhages and and of course the prognosis. Now you see from the other series here in 2003 from Jivas, we have an overall mortality of 69%, so pretty high. But again, for the lateral tegmental, only 15% Now again, looking at this a little bit better, so the hematoma size correlate with birth outcome. The unilateral tegmental have a more favorable outcome, but the massive and bilateral tegmental have really poor outcome, and ethically you really have to decide whether you treat them further on an intensive care unit and send them to rehabilitation. One more thing, maybe you listened to my first talk. Now, any kind of hemorrhage that also destroys the superior peduncle, cerebellar peduncle, can lead to this, again, to the inferior olivary hypertrophic degeneration. And this is due to the basically damage of the triangle of Guillermo-Larrey. And again, these patients are very, very difficult to treat, to rehabilitate. So this is an MRI that was done later on. And if you see these degenerations, then the prognosis for a good rehabilitation is basically very bad. Now, looking on the recommendation scale, you see this is the classic class 1, 2, or 3 recommendation which treatment should be done. And there is definitely a recommendation for cerebellar hemorrhages. When the patient is deteriorating, then the patient should be operated. And interestingly, and I have to admit, now going through this data again, I sometimes think about an EVD drainage before we take the hematoma out, or even just for the hydrocephalus, but the evidence really shows that only EVD drainage for infratentorial big hemorrhage is not recommended. So if you want to do treatment, then really go for the resection for the cerebral hemorrhage. And that again has a very good evidence, and it is recommended to do it when it's over 3 centimeters. Whether you should do it early, so when the patient is still very good, or first when the patient deteriorates, there's not a good evidence for this. So you don't have to do it very quick. You can wait until the patient is really deteriorating, and then you should definitely do it. That's what the guidelines say that were published in 2017, also in the neurosurgery and stroke issue. There are 2 series, or very small series, that advocate brainstem surgery for brainstem hemorrhage. The one on the left side, also again my teacher Hermann Betalanfi is involved in these. It's interesting, the modified ranking score left side was very bad, so classically not cavernoma cases, but really hypertensive hematoma cases, and 4 out of 5 had a really good outcome. So that's interesting. Of course, there's a bias, it's a retrospective series, small series, but the group of Zhang On the right side, again, published in Journal of Clinical Neuroscience. Here they had a conservative group and a surgical group. And here you can see again that the Glasgow outcome score was better in the group with surgical resection, but overall the good functional outcome was 5 patients in the conservative group and 8 patients in the surgical group out of 28. So we're not talking about a treatment that will help all of them, but only a very few of those patients it might be helpful. So definitely no recommendation for surgery, but also one cannot say that there is no recommendation or you must not do it. So in conclusion, the primary brainstem hemorrhages have really the highest mortality rate of all intracerebral hemorrhages. Really distinguish between primary and secondary hemorrhage. That's very important. The surgical treatment is not yet a standard of care, and the treatment remains conservative with the intensive care unit management. And there is some evidence also for an EVD. If there is hydrocephalus, of course, then you can certainly proceed with this treatment before the patient comes to the intensive care unit. Now, I thank you very much. I took a minute too long, I'm sorry, but I'm still open for questions. Thank you very much.